there's a reason we do things. So we should know what the potential is to happen or the risk for that if we skip this step before we decide to skip it. And that's part of the foundation in education and training. Don't just do it because that's part of the routine. Do it because you understand the why and the what can happen if you don't.
Clock in, scrub up, and join us behind the red line, where infection stops and information starts. You're listening to a special combined season of First Case and Transmission Control podcasts, bringing perioperative practice and infection prevention together to tackle one of healthcare's most persistent challenges, surgical site infections. Each episode will connect you with frontline staff, perioperative leaders, infection preventionists, and healthcare innovators sharing real-world strategies, stories, and solutions that are changing the way patients receive surgical care. From the back table to the boardroom, from wheels in to wheels out, and from surveillance data to safer practice, we're breaking down silos and strengthening the systems that protect surgical patients. Welcome to Silo-Free Surgery.
Hello and welcome back to another episode of a special combined season of the First Case and Transmission Control podcasts. Today, we're going to be joined by Julia Jackson, an expert in both infection prevention and the operating room, to talk about a framework and a mindset that significantly impacts surgical site infection prevention, and that is surgical conscience. We'll be right back after a brief word from our sponsors.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
Hello and welcome back to another episode of a special combined season of the Transmission Control and First Case podcast. My name is Garrett Hollembeak, Editor-in-Chief of Transmission Control. And if you've been with us this far in the season, we are very excited to talk with Julia Jackson today. And again, you've probably noticed the theme of us bringing on guests that have the OR background and the infection prevention background. And Julia is perfectly in that wheelhouse. So Julia, welcome to the podcast today.
Thank you so much, Garrett. I'm happy to be here.
Yeah. And we're happy to have you back. Julia was on our first season of the Transmission Control podcast. So go back and listen to that as well. But Julia, for those in the audience that don't know you, tell us about your background and your experience both in the OR side and in the infection prevention side.
Sure. I began my adult life as a certified surgical technologist. I worked in the OR since the 90s. I worked in the academic setting. I was director of surgical technology and sterile processing programs at Baker College. Following that, I became an infection preventionist at the University of Michigan. I was on the SSI team. That was one of my responsibilities, as was all things HLD and sterilization. But I scrubbed in the OR a long time, and I'm an educator by nature, lifelong educator, lifelong learner. And so I've been doing what I love for the last 25 plus years, and I'm really happy to share it. Anybody who knows me knows that.
and that's the great thing about it, because so many of these conversations, it all balances on somebody's experience that's been through this. There's no better teacher than experience. And in this conversation, we wanted to take this IPSP, Julia, I did this on last episode. I did IPSPD, but it's always part of the conversation. But infection prevention, OR conversation from the perspective of surgical conscience. So let's start there. If you could define surgical conscience for the audience, or maybe for a new learner, how would you define that?
It means to me not being afraid to do the right thing. We've got an obligation to patients to provide a safe operation. We want to prevent injury, prevent harm, prevent infection. We want to do whatever is in our control to protect them. And, it's not optional. It's just, that's our duty.
Mm-hmm. And one of the challenges, I think, is speaking up when it comes to, hey, I saw something. And I always wonder, are people afraid to speak up because they don't know the exact right thing to say? Or is it because they worry about getting somebody else in trouble? Do they worry about being in trouble? I don't know. What have you seen in your experience with when people are afraid to speak up?
I see it with, a lot of new people, but also some veterans. Intimidation is a big one. It's a big part of it. They may be new to the environment or they still learning and they think they shouldn't speak. It's exactly the opposite. Speak, don't assume, just ask the question or make the comment, be professional, but don't assume that you shouldn't ask it because that's when things happen and bad outcomes happen. So the protocol exists for everyone. It's not arguing. We don't take it personally. We protect the patient.
Yeah, and I think we've all been in those situations where you're like, I don't know exactly maybe I don't know the step-by-step Lippincott way you're supposed to do this, but something about what you just did doesn't seem right. So can you walk me through it? Can you explain what you did? And maybe let's figure it out together. And that can take a lot of courage to step up and say, hey, I don't know the right way to do this, but the way you're doing it doesn't seem the right way to do it. It seems like we're putting somebody at risk there.
Absolutely. We should be asking those questions and it should be encouraged. Unless the patient's bleeding out, then maybe wait.
Yeah, just give it a minute. Yeah. If you're talking about dust bunnies when somebody's in an emergency situation, we got to time that out. But have you seen that where somebody has spoken up in real time and really demonstrated that surgical conscience, either from an IP side or an OR side?
Many, many times. I'll share a story. When I was back in the OR full time, I was scrubbing an open abdomen, open belly case. It was a bowel case. We had, laps packed in. We were taking them out. We're starting our counts and doing our cavity count. And I told the surgeon, I said, listen, my count's off and we've already recounted. Can you check the wound again? And he says, I'm sure it's not in there. I did a really thorough job. I'm sure it's not there. I said, can you just please check another time? And, after a couple of minutes, he just said, okay. And you know what? It was there.
There it was. Holy cow.
Yeah. It feels like tissue when it's in there. So, and, that's just one of the things, but it's like, it's not worth an argument because we're all trying to do the right thing. So it was helpful.
Now, let me ask you this, that surgeon, after you had pointed that out and really kind of pressed it to say, hey, there's something not right. We need to double check. Was that met with gratitude? Was it met with getting chewed out?
I've been chewed out many times, but I did not get chewed out for that one.
I think that's great for people to hear because you got to be courageous and even risk being chewed out sometimes.
You do. And you have to understand it's a situation, not the person. It's not you, it's a situation. And sometimes they get overwhelmed and, but he wasn't, he checked and then he checked again and finally there and, okay, great. I'm so glad it was there. Thank you. And, I didn't get chewed out for that one and it turned out the right way, thankfully.
That is. And, the patient walks away not knowing that you were there to stop the line and demonstrate surgical conscience, but they're better off for it.
Exactly.
Now, because you've done so much education and training other clinicians and healthcare professionals, how do you teach surgical conscience? How do you get that instilled at a base level with somebody?
So one, modeling. So everyone and, instructors, everybody, you should be modeling that behavior. And then attention to detail, standardization, and consistency goes a long way. We always count in the same order. Field to Mayo to back table to floor, and checklists help, but integrity can't be checked off. It can't create integrity. It's about modeling behavior, being intentional, even in practice. I used to tell when I coached my daughter's teams and when I was coached by, my high school softball, volleyball coaches, if you do it in practice, you'll do it in the game. So don't cut corners just because it's a classroom or the sim lab. Create the right practice and do it every time.
That may be the quote of the episode, that a checklist can't build integrity. That's something that it's intrinsic, and checklists definitely support that, but you can't have a perfect process everything in the OR it's very human. Checklists and best practices support that, but you never know what's going to go on in the OR. So you have to have those fundamental character pieces in the mix as well.
I agree.
Now, when it comes to seeing both sides of that coin in terms of training, how are surgical technologists trained in infection prevention principles?
They start very early. One of their earliest classes is microbiology. There's pathology, anatomy and physiology, medical terminology, but also with sterilization and what the log reductions mean and disinfection, the different levels, and then sterile technique. I mean, they get it from every angle. And, I always say, if you can give it to me frontward and backward, then you know it. And, so they have a lot of exposure, and it's pretty exciting when their light bulb goes on, and they see it all put together, in the real world, and it's working.
Yeah, that's a really good point, because it's all almost theoretical. We know germs are out there, but when you see the patient on the field, you're there to protect them. As a scrub tech, I think we forget that's really your patient advocate in the room. Everybody is, but that scrub tech is closest to the patient for the largest portion of the procedure. They're really there keeping them safe throughout the whole time.
Absolutely.
And we'll get emails and messages that, yes, everybody in the OR does it. That's true. But when you're right there with the patient and you're watching them the whole time, it's a different thing than we may experience for circulators or anesthesia or the surgeon themselves.
It is. It's, everybody has their aspect, and it's a very important job, but we're there in the front line, and I love it. And I don't ever want to stop being connected to the OR in some way.
Yeah. It's a community.
It really is.
If you could take one learning objective about infection prevention and make it like mandatory learning for all surgical technologists, is there a principle that you would have everybody know, or something that you would reinforce with that?
A lot of times, and I'm very much on integrity, truthfulness, justice, things like that. And, remember, it's not about us. It's not about the surgeon. It's not about anybody's ego. It's about that patient. That's the only reason we're there. Take your time out seriously. Don't talk over them. Turn off the music. Remember the patient first. The Association of Surgical Techs, it's our professional organization. They got primo the patient first. Want them to get through that procedure safely. We can have fun at the same time, but don't ever be afraid to do the right thing.
Mm-hmm. Does that require a culture, a specific culture within the hospital or the organization to have that culture of speaking up?
It does. Absolutely. And it starts from day one. It starts, in your orientation. And you can pick up pretty quickly, even when you're a student there for your clinicals. We did 600 hours, but, some people, even if you're burned out or you're ready to retire, I've seen folks that are, 110% all in on that, surgical conscience. And then, I've seen some folks that didn't take it as seriously as they should have, because it's, it's their 1 millionth hernia repair, but it's that patient's first hernia repair. And, they kind of sometimes lose that piece, but overall, I think everybody's super dedicated.
Yeah, I think that's true. And it's one of the things that makes healthcare clinicians great is I think everybody's got that in the back of their mind. This could be my parent, my spouse, my child here on the table. And that's the attitude we're going into this case with.
Absolutely.
Now, one of the things that came up as we were discussing this episode, and it really stuck with me, was the really reinforced practice in the OR of if somebody points something out to you, that it gets corrected in real time. There's not an argument or debate in that moment. And that's probably counterintuitive to what you've maybe seen on the IP side, because I think every infection preventionist listening has gone rounding on the floor and said, hey, your isolation sign's not up, or hey, this dressing needs to be fixed. And sometimes you get a lot of pushback to say, well, I just fixed it, or there's this thing, or we just got an admit.
That is true.
And so you get, I don't know, I felt like you can get some pushback there. But in the OR, that's not typically the culture. Typically, it's what is the culture in the OR when it comes to pointing out something that didn't go right?
The first thing we say is because everybody's going to contaminate at some point. It's just a matter of when. The important thing is to learn what you did and prevent it from happening again, right? Because everybody's going to make mistakes. Surgeons make mistakes, everyone. Let yourself learn from that, but will somebody say, "Oh, I think your glove brushed that," or looks like you got a small hole, or here, doc, can I change that glove real quick? And they say, "Oh, yep, sure, just give me a second right here." Or I say, thanks for catching that, and we'll just get this done real quickly. I can count on one hand in my years and years that someone actually said, no, I didn't touch that. And it's usually been a visitor or, someone in a learning role, right?
Sure,
Could be a resident or intern
Might
or whatever.
Might be an IP observing the case.
Oh, it could be because, not all IPs, that's one thing. And, the OR and sterile processing, those are subspecialties within IP. So usually IPs in the beginning, they stand against the wall and don't move. They don't talk, they don't move, they don't do anything. But then you learn you learn the culture, you learn the routine, you become part of it, not just standing on the outside looking into it. And it's, the more good you do, the more good is done.
That is very true. That's such a unique culture there. And it makes you think how different other aspects of clinical practice would be different if the immediate response was, thank you for pointing that out, I'm going to change it immediately. Is there ever like a debrief afterwards, or to say like, hey, I didn't really, is there that, or is OR just so busy that there's not time for that quibbling?
Sometimes we do a debrief if something really went wrong or something wasn't available. We'll stop and talk about it, do a debrief, after the dressing goes on. And sometimes we just don't have time. It depends. But, we try to. When the heat is off, then we try to say, hey, listen, this is what I meant, or I should have done this, or, I apologize for delaying, or whatever it is. But I think the debriefing is super important, and it should be done more often, not only in the OR, but everywhere. The why behind the what, why did this happen? How did it happen? How can we prevent it?
That's a great point too, because if it's happening in one case, it's likely to happen in another case, or it already is happening or has happened in another case. So kind of breaking it down can help you prevent it in the future.
Absolutely. That's what it's for. Absolutely.
And I want to go back to the timeout piece, because I imagine you've seen an evolution of the timeout process in the OR over the years, and how it's been kind of reinforced and refined. And when we're doing timeouts, how have you seen that timeout period support infection prevention practices in the case?
Well, there's the anesthesia timeout, which is the first one, and that is antibiotic dosing, right? Was it an IV push? Was it Vanco? Vanco needs to be started 90 minutes before the incision, right? And IV push is started, 5 minutes before the incision. Which is it? Are you dosing for the right weight? Is it the right drug? Is it at the right time? So that's a huge deal, because that's got a very high impact. And is this patient resistant to it? And that's one of the things. Does this patient have a history of blah, 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 resistance, colonization, things like that. And then, I've seen some really, really good timeouts, and I've seen some pretty crappy timeouts.
Yes,
so, they leave the music going. Okay, we got to get this done. Here we go. My name is, and they leave the music playing, and somebody else is talking, or their back is turned and they're doing something, counting or whatever. Yes, you have to do that, but now's not the time, because we could miss something. And, they really, you should go through, depending on what kind of case it is, do we have the instrumentation we need? And surgeons learn that part pretty quickly. It doesn't take long. And then the surgical technologist as well. We don't want to get caught up in that. We don't want to delay the case, and we don't want to, that patient under anesthesia. So it means something. Take it seriously. And then, there's usually the circulator who starts it. And if that person, they kind of play off of that person. And, everybody who worked with me knew I had a reputation for not taking shortcuts and doing it the right way. And so they know I'm not going to, hand the knife before this, or I'm not going to, I'm going to do the timeout the right way. I don't care if it takes an extra 12 seconds, that's the way it's supposed to be done. And I admire people that do that. And the more you do it, I think, and a model for your students, of course, but, it's just, you have to develop that. It's part of the culture, and it's the expectation, not an aberration.
Yeah, it's like the practice thing. If you practice a good, solid timeout every single time, if you take all the steps, you get more efficient at those steps. And with turnover pressure being, I feel like an increase.
Yeah.
I could be wrong in that, but it feels like turnover is a continuous conversation with get it faster and faster and faster. And there's a point where you say, all right, how fast is too fast with a turnover?
Oh, yeah, for sure. It's, splash and go. I call splash and go. I do that in a lot of different situations. Yeah, it's basically, like you just get, a $2 worth of gas, splash and go, in a hurry. And, it doesn't fly. There's always that chance. And there's a reason we do things. So we should know what the potential is to happen or the risk for that if we skip this step before we decide to skip it. And that's part of the foundation in education and training. Don't just do it because that's part of the routine. Do it because you understand the why and the what can happen if you don't.
Yeah, and that makes perfect sense. Are there surgical site infection risks that are at a greater chance of happening when we're moving too fast?
Oh, absolutely. Absolutely. Bad prep. Don't let it dry. Fast draping. You're moving the drapes around. All of that, especially if you're doing extremities, those take longer. You do a less than proper prep, or you don't do the, preoperative nasal prophylaxis or decolonization, or you don't do the pre-op clean, with the wipe down. Sometimes they do that. All those things impact it. And when I've called surgical site infections, I've seen there's been multiple of those things happening, but also there's just been some others there wasn't. But you definitely have a much higher risk. Definitely have, and those are the things that I see. It's the preoperative stuff and counting and opening and prepping and draping. Those are the rush things.
So again, the setup is just as important to SSI reduction as the intra-op activities that are going on.
Oh, absolutely. Absolutely critical.
I think that's one area where your expertise on both sides of the table really help, because I imagine you see risk factors during certain points of the case that maybe a newer IP or even a seasoned IP that has not observed a lot of cases they may not catch that it's a risky point. What are some of those risky moments in a case where contamination may take place?
There is what everybody's gowning and gloving, right? And that's there's a high potential there. When you're doing a procedure in a clean, contaminated space, like you're doing a bowel case, or you're doing something in the throat or the stomach, things like that, right? So it's controlled entry into a contaminated zone that's clean, contaminated with no spillage or infection or things like that. A little spillage or a little nick or we don't have that suture. Can you go with this one? Just little things like that. Or, this instrument fell off and, things like that. These little things may not individually make a difference, but we call it the Swiss cheese effect. They're all different Swiss cheese holes. And when all those things line up, I've seen it happen, right? It's just bad closure, right? If the closure is not very good, you're going to get a wound hissance, and then, it could be an abscess. It could be just leaky, icky, schmutzy. But, it's a negative outcome for the patient, and they have to spend more time under care or in the hospital or at the doctor. So it does matter.
Yeah, it really does. And that aggregate perspective is, the patient knows that there's going to be risks of surgery. It's part of the informed consent. But there's, given that, assuming things are going to go kind of the standard way. But if we have a lot of small hiccups or a lot of small deviations, those do significantly pile up to result in greater risk for the patient.
100% they do.
One area that always kind of made, when I was observing OR cases, that I always kind of wondered, is this a risk point? Is people coming in for relief or like breaking for lunch? Yeah. And that always seemed like a tough thing because there was a lot of motion, a lot of doors open. And, again, coming from the perspective, I don't know if this is a good thing or an expected thing or a really bad thing for the patient, but it seems like an opportunity for us to maybe tighten this up somehow. So is that a risk area just with people in the room or handoffs during the case?
It is. So I read a paper, of course, now I can't cite it because I'm me, but, they studied that, how many times the door opens. And I've counted door openings in so many cases I can't even remember, but there's been hundreds of door. We used to, hey, how are you today? Oh, can I borrow a pack of sponges? Oh, do you want a break? Oh, do you have any of this drug? And so now it's a lot less tolerated, but I was one of those that's like, I always felt really guilty breaking for just your coffee, like a 15-minute break. Depending on where we are in the case, because I don't want to disrupt the cadence of the procedure for the surgeon and the surgical team by leaving. 2, the door opening, someone gowning and gloving, me breaking scrub, me giving report. To me, I'll say, I'll skip it. I'm good. I don't, it's not a good time to go. And if they can't get back to me, then that's okay. But, on the other side, sometimes people need to use the restroom or you eat your lunch.
If you're standing there for hours and hours and hours.
Yeah, common sense, but time it the right way. You're getting ready to put an implant in is not the right time to go to lunch, right? It's just not. And we're getting a lot better at that. And the no traffic, we used to put signs on the doors and caution tape up and people would just crawl underneath it. And they did.
Yeah, I believe it.
But nowadays it's enforced better. It's much better, but that's just, you're not thinking of the patient. You're thinking about you. You're taking things for granted. Think about, so you're breaking the laminar flow, right? If there's laminar flow from the ceiling down to the floor, coming out of the ceiling or whatever, it's going to hit a person, or if somebody's moving out of the field, that's going to redirect that air sideways. And what's sideways? Well, the back table in the field is right there sideways, right? It doesn't go all the way down, right? And, putting things in the way of the flow, all those little things that people may not pick up on. And I've been very lucky because I've been on the front end, and also I've been an IP that's done the chart review and the outbreak review and the SSI reviews. So I see that, what happens to the patient. So I try to share that with the team. And that's a big part of what I did, when I was an IP in the hospital is keep it, I don't want it to be too generic, and you want to direct it to the right team. So if it was an event, I do a really nice summary for the OR team that was there in the case. I may present it differently overall with the numbers and the rates, but they really want to know. Some surgeons feel, oh, wow, you're picking on me. I'm like, I'm not. I'm just providing you this information for your assessment, but I'm calling this an infection because this, and this. So.
Yeah, and having that data is really powerful and kind of the new flow of information. I remember when we would run trays up to the OR, one of the rooms was the laser room. And, the rule was, hey, if you see glasses on the outside of the door, do not go in. You can call into the room, drop the tray off outside. And I had one of my staff members open the door. And as we were talking about it, we talked about, hey, the risks for everybody, really, but especially her. And her response was, well, the glasses are always on the door. They're on the door every time I've gone up there. So it told us like, hey, the signal that we think is useful, and it is, people are so accustomed to it that it's stopped meaning something.
That's an excellent point.
And that's easy to happen. We see signs everywhere in a hospital that it makes you think maybe we need to switch them out or use different solutions, or really like when the house lights are on in the OR, that means we're putting in an implant. Nobody comes in, wait till the lights are actually, I don't know. I feel like technology can really help support some of those, but,
I totally agree.
Yeah. Those things we grow nose blind to.
Yeah, that's exactly right. And they interpret things differently. Somebody new coming in may interpret it as this, but, we all know that this is what it really means. So that's a big, big deal. Or this is the way we've always done it. It's the same kind of thing. Don't dig your heels in on those, because we need to be very clear in what we say up front, because explaining it after the fact, doesn't do a lot of good to the patient that just had to have another operation.
Yeah. And hindsight being 2020. And I'm glad you mentioned those little things that IP can observe when we're in the room. So I'm curious to get your take on what things should IPs be doing when we're observing a case, and then what things we should not be doing. And I'll add one more at the start there, is how often should IPs be observing OR cases?
I think it depends on how big your OR is and what kind of cases you do. They say annually, but I was in there all the time because I go by each service, right? So I do cardiac, I do ortho, I do general. So I'm there more often, and I do
did each service annually. So like you're going to, that's a very smart idea.
Yeah, because they all have different procedures and they just have different procedures, different patients, and it's good to be seen there. Boots on the ground, go see, Gemba. You can't make assumptions, and it's impossible. The more you know, about the environment and the interactions and the techniques, the better off you are assessing it afterward. We look for things, and so try to brush up on basic OR language and like workflow. You're not going to be able to catch everything, right? You're not. But, you're not going to critique the sutures or the surgeon suturing technique. You may in your head. You can in your head, right? But, say, oh, that staple line. Oh.
Yeah, you might not get invited back to the OR if you're sitting there,
Correct. But you can look at the traffic in the room. You can ask the person that's performing the surgical skin prep, how long does that have to dry? Or why did you start there instead of over here? Do I like go with a foot or toes or legs, extremities? Well, why do you start there? Or why, we do it differently. We go back and forth, but we have an extremity. Do you go in the circle? Why do you, look at the labeling of the liquids on the field, right? Look at the sharp safety on the field. Try to look at the draping. There's a lot of education and videos out there that you can because nobody knows everything. I try to buff up on those things and just revisit it before you go back in. They always say, don't touch the blue, or if you're going to pass out, fall away from the blue.
Yeah.
We love you, but don't fall on the patient.
Yeah, but, we don't need two patients in the room.
Yeah, read it, try to watch some videos or, just observe first and then, start breaking things down. And usually it's the start, circulator, how they count. That's a huge deal, right? How they open.
Yeah,
I always try to get in there.
Yeah.
No, before they start opening, I got to get in there before they start opening, not at incision. I'm there room turnover and from out of the gate when they're setting up the room. And that's the most important time in the case.
That's a really good point too, because some of those things, labeling of the fluids on the table, we may not directly think of that as an SSI prevention measure, but it accounts to that aggregate effect of, hey, if something's going to go wrong, are we catching the things that may not be going according to best practice?
Right. I mean, clear fluids look all the same basically when they're all in med cups or whatever. So why take the chance? Label the syringes, and it's a requirement. It's not a nice to have. You need to label the stuff on the field. Yeah, it's a huge deal, and we used to not label anything.
Now it's clearly the other way. Everything's labeled and barcoded, and maybe not barcoded, but
the sponges are barcoded.
There you go.
They
That's
can
awesome.
scan those. Yeah, and that. In the beginning, as people are like, oh, this is going to slow us down. But guess what? It works, right? If you do it, so it's a trial and error thing. You have to find the routine that works. There's a lot of different ways to do it the right way, but you have to find the right way that works for your team, right, in your type of case.
Yeah, that's such a good call out, too, because I think there's sometimes an imagined tension between compliance and efficiency. And IP's here just banging down your door about compliance, and, administration is banging down your door about efficiency, and the OR can, I imagine, feel a little bit stuck in the middle. And that's maybe a false dichotomy to say you can be compliant and efficient, but we have to practice and play compliant and efficient.
Agree. It just doesn't come automatically just because, you know how to do it. And there's always something that happens. Always something comes up. Doesn't matter what it is, big or small. Something's going to happen to shift, and you have to react, quickly, correctly, and calmly. Keep your wits about you.
Yeah, and the real time piece of it is super important. When it comes back to doing the surveillance piece of an SSI review, what are some things you would recommend IPs looking in the chart for that maybe we may glance over or may not take into account when we're looking for trends?
So we're looking at the operative record. We're also we spend a lot of time on the anesthesia record too. So I always start with the anesthesia note and the preoperative notes. So did they explain the education for the showering protocol or the nasal decolonization protocol to the patient? Did they just hand them a piece of paper, right? We did a lot of work on that. Is patient comorbidities, patient weight, patient temp, glucose preoperatively, was there warming performed? Okay, what was it? Right? Dose will put yes. And they put the dosage, the time, and is it IV push or is it, infused over 90 minutes? And that's super important, right? And did you redose at the right time? And was that redose the same dose or is it a half a dose originally by weight? I mean, every drug's a little bit different. And over a certain weight, usually like over 200 pounds or whatever, you have to go up from 1 gram to 2 grams of Ansef or whatever and make sure that was done. So I read those anesthesia reports. Those have a ton of information. And the operative note, we're looking at any intraoperative incidents, like was anything nicked? Did they see anything that didn't look right? Who closed during that procedure? Did they irrigate with anything special? Did they use intraoperative antibiotics like antibiotic powder or antibiotic spacers or, some things like that? Did they, in a clean case or even a clean contaminated case, clean contaminated is a controlled entry. Contaminated, right? So, class 1, class 2, but class 3 is a contamination event occurred, right? You can't automatically be like something happened and then dirty case. And people say that's a misnomer that I one of my pet peeves is, oh, this is a dirty case. It's the butt. It's not a dirty case. A dirty case means it's infected, right? There's pus. There's an abscess. That's a dirty case. This is a clean contaminated case. Yes, it's the butt, but it's controlled entry, right? There's no perfs. There's no, so understand that whole concept too, because that's also the risk changes. Is it sterile tissue? Is it clean contaminated? That raises your risk from like 3% to 11% or whatever it's going to be. Then 3 bumps it up even more. And obviously, a contaminated or a dirty case, infected case, it was affected at the time of surgery, so that you can't attribute an SSI to somebody that comes in with pus in their belly, unless it's from the previous surgery that we did.
Right. Yeah. And documented appropriately. That was a big focus of our last episode was, what PATOS documentation counts.
Nice. Yes.
Now I'm curious because there's so much nuance, and this is a question we've asked some of the other guests on this season, is because there's so much nuance in the OR and SSI surveillance in general, is there a benefit to having an IP who's dedicated to the OR or maybe to the whole peri-op loop where they're looking at PACU, SPD, the OR, so that they can really dig deep into those nuances?
Absolutely. We had 4 people on our SSI team at Michigan. So yes, it's, that's primarily what we do. Then we may have ambulatory or, a couple of floors, but the same group is reviewing, for SSIs. That's the way it should be because you have to see the big picture, isolated events in a vacuum. It's not about this happened at this time on this day. It's the trending, right? The trending, is going up for this and, like breast implant infections or, we had colon resection back when we did a lot of opens. We were upwards of, I've seen hospitals with 35% infection rates. And, that was back in the day. And, bowel technique, what's bowel technique? Back when it was optional. So, it does. It matters absolutely. And you should be, do education among yourselves too. Get education, provide education and understand what the process is. A lot of people think, everybody, when I first started being an IP and I talked to other people, other IPs, well, everybody in the operating room has, is sterile and they're wearing a gown and gloves. I'm like, nope. just the surgical team, right? And they're like, oh, I'm like, why do we need to, hone in on that much? Well, this is why not everybody's wearing that, a handful are. So that's a good example that I use a lot. You have to get in there and see it. You can read about it, but you got to go experience it. You got to experience it in person.
Yeah, and experience it with a friend. One of the best OR observations I did where I learned the most, and this was pretty early on, but I wanted to see everything from the central line being placed in a cabbage case to, through the procedure out to PACU. And this was just because I didn't know enough and was very acutely aware that I didn't know enough. And our OR educator was very kind to come in and observe the case. And that helped not just for them to say, hey, this is who this person is, this is the circulator, this is what they do, but also just to say, hey, we do this way, this is a new initiative, this is why we're doing this. This is the perfusionist. I'll tell on myself here, I didn't even know perfusionist was a job. So you almost have to have that buddy if you're new to the OR environment to say, hey, this is the rules of the road when you're in here.
Yes, definitely.
So as we round this episode out, Julie, I want to ask, what are some go and do's that both IP and the OR can do to support SSI reduction?
Get to know the teams. Get to know what drugs they use. Get to know, what type of drapes are used in what type of procedures. Why do you use this prep? How do you do this extremity versus, this belly? The products that they use, be familiar with them. And that comes pretty early, but how they're actually used, a lot of people have no idea. So spend a lot of time observing, ask questions, and then, you're learning, but they're learning as well. And, we do a lot of information exchange, and there's some great dialogue that takes place. And like I said, don't ever be afraid to ask a question. And, unless, got to use common sense there, but that's how we all learn. Right. And in the olden days, don't talk to me. I had one OR manager. It was, many years ago, but I'm a person, I go in and I engage with staff. Hi, how are you doing? Because I'm very comfortable in there. I'm like, hi, I'm Julia. I'm here to observe today. I'm an IP, blah, 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 blah. And I asked what the person, the circulator that was doing the prep, I said, so I see we dipped kind of into that axial region and we came back out up onto the breast. Do you think we should go over that again? Or what is your protocol if that happens, or you dip down into the middle of the crack and go back up the spine? And everybody in the room just stopped and looked at me like I had three heads. And then it's like their culture was, I wasn't supposed to talk to anybody directly. Okay. I was supposed to go through the OR manager. I'm like, well, that's not how it works. I'm sorry, but that's not how it works. And, the same thing with the tracer. The surveys are supposed to do the same thing, but that's my job. That's absolutely my job. And so, that team may not have been exposed to, actually, they didn't have any IPs doing that. That's why they looked at me that way. But yeah, it's a great exchange because you learn and they learn, and everybody's better for it.
It absolutely is. And that exchange of information, that collaboration in real time and, before the case, after the case, that's how those silos break down.
Absolutely. Yeah, definitely. No question.
Julia, I want to thank you so much for joining us on this episode and just sharing a wealth of wisdom. Where can people reach out to you and find you if they have additional questions?
Sure. I am on LinkedIn. And my email is juliaajackson@icloud.com. And the rest of my contact information is on LinkedIn. Feel free to call or text me, email, ping me on LinkedIn. I'll be happy to help answer any questions that anybody has.
Awesome. Well, thank you so much. And thank you to our audience from both the first case and the transmission control side of the table. We're grateful for you guys for listening. Feel free to drop a comment, share to an IP or an OR colleague. Thank you, Julia Jackson, for joining us on the podcast today. Anytime we have her on, it's going to be a great episode, and today was no exception. One of my favorite things talking with her about was, having that infection prevention and operating room background kind of seeing both sides of the coin. It's such a unique position to advocate for surgical site infection reduction measures and being able to do that, speaking the language of both the IP and the OR. We've talked a lot about breaking silos down, using good communication, and there were a ton of great insights in this episode of how we can kind of take that into practice. Thank you to our audience for joining us today. And remember, infection stops where information starts.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.